This is also, like I said, called the neuro hypothesis. The anterior is called the adeno hypothesis. And this one's mainly made of nervous tissue, like we talked about. And posterior pituitary is more of a storehouse for the hormones, whereas in the anterior, it's where the hormones are secreted or made. Here, the hypothalamus makes the hormone and then sends it down. Those talk and stored in the vesicles in the posterior pituitary. And we kind of already talked about that. They are innervated by supraoptic nuclei. They are what secrete the ADH. And then paraventricular nuclei are what secretes oxytocin. And so those are up there up in the hypothalamus. And then when you get stimuli, then those nuclei are what sends the signal down the pathway for the posterior pituitary to release those hormones. And it's sensitive to damage because sensitive to neuronal damage by lesions that affect the pituitary stalk or the hypothalamus, because that's where it's being produced, in the hypothalamus. So in the posterior pituitary, like I said, it secretes ADH and oxytocin. So ADH is really no disease per se, so we will only kind of go over that. Mainly oxytocin stimulates postpartum milk letdown in response to suckling. So there's really no disease. However, ADH, you have two diseases that mainly we'll talk about. ADH is released into the bloodstream when the body becomes dehydrated. And then it concentrates urine by triggering the renal tubules to release water back into the bloodstream rather than excreting it into your urine. So that's how normal ADH works. So, and then oxytocin also is related to contractions of the uterus. Again, you'll get that when we get into women's health, because that's why they give women Pitocin, which is another term for oxytocin, to cause them to have contractions and help get the baby moving. But today we'll mainly talk about disorders of ADH. And did Professor Paul talk to you guys about hypertonic osmolality and all that in physiology? Again, ADH is made by supraortic neurons in the hypothalamus. These are things that can stimulate the hypothalamus to send signals down to the pituitary, posterior pituitary. So low blood pressure, so you have low blood volume, high plasma, osmolality, pain, or emotional stress. These are all triggers to produce or to send out ADH. And then here is just osmoreceptors. Just talk about those two that help aid in the thirst regulation, ADH release. And then these are things that inhibit ADH. So alcohol, high blood pressure, and low plasma osmolality would inhibit ADH release. So diabetes insipidus. Has anybody heard of this term before? Mm-hmm. Did she talk about it already in diabetes?
Dr. McNeil's talked about it.
Oh, he has? Okay. Diabetes insipidus, I never saw it in internal medicine. I did see more SIDH, but diabetes insipidus, you most likely will encounter it more in ER maybe. So again, the nomenclature kind of confuses people because they think it is associated with diabetes mellitus, which it is not. Even though they both have polyphagia and polydipsia, they're not related at all. Because remember, with diabetes mellitus, it has to do with glucose, and then the diabetes insipidus is mainly just from ADH. So with diabetes insipidus, it's caused by damage to the pituitary gland or the hypothalamus. And the damage disrupts the normal production, storage, and release of ADH. The passage of a normally large volume of urine that is insipid. So insipid means that it's a large amount and that it is dilute. Dilute and odorless is what insipid means. So diabetes insipidus is loss of ADH secretion or loss of ADH action. So decreased ADH decreases water reabsorption, results in increase in dilute urine output. So increased serum concentration. So these people who are diabetes insipidus are euvolemic, hypernatremic. So these are the people, like if you imagine a cup of water. Well, let me back that up. So these people, they pee out a lot. Normal people pee out like 1 to 2 liters. They're doing like 3 to 5, something like that, crazy. So they're peeing a lot. So imagine a cup. The cup is going to be empty, right? It'll be down here with water. So it'll be full of what else in the cup? If it has not enough water, we'll have all the solutes, right? So that's why they're hypernatremic. And there are several types of diabetes insipidus. The main ones we're going to hear about is central and nephrogenic. Now you can have dipsogenic or gestational, but gestational is just the term. It's more in pregnancy. So central is damage to the hypothalamus or pituitary gland. You get the decreased ADH secondary to some intracranial process, usually remember, it's usually from an injury or from surgery that people can develop diabetes insipidus. And then nephrogenic is the kidneys don't respond normally to ADH. And those people, it's usually from a defect in the tubules. It can be inherited, or it can be from chronic kidney disease. And then dipsogenic is usually someone who has a problem with the thirst, a defect in their thirst mechanism. So these people are always thirsty. But a lot of times this one is associated with mental illness. So people will just drink, or they have a defect in their thirst mechanism, but the majority of it is because of mental illness. And then gestational is during pregnancy, and the placenta breaks down the ADH and produces more prostaglandins that reduce the kidney sensitivity to ADH. So that occurs when you're pregnant. Deliver the baby, you're back to normal. So how does one develop central diabetes insipidus? We kind of talked about. More commonly, it's surgery, skull-base fractures, injuries, tumors, or infections. You can have, it's not as common, but a primary cause of diabetes insipidus is usually from a chromosomal disorder. So, but majority of them are idiopathic if they're young. They're found in a child. But most adult ones are usually secondary causes. Does that change? That didn't change, y'all did it. So signs and symptoms. So like we said earlier, they pee a lot. So lots and lots of high volumes of dilute urine. The polyuria produces symptoms of urinary frequency, nocturia, so the patients may get up at night, disturbs their sleep, they have daytime fatigue or somnolence, and usually these people have polydipsia as well, or polydipsia. They're drinking a lot, and they may have dry skin, dizziness, nausea, they're confused, and these people these are your dry people, right? So they'll have low blood pressures usually. They become hypotensive or have postural or orthostatic hypotension, and they are hypernatremic. And then, how do you diagnose it? You do proper family history, physical exam. And then look for signs of dehydration. So remember, we're doing physical exams. What would you look for someone who's dehydrated on a physical exam? Skin turgor. Mucosal, dry mucosa. And obviously their blood pressure could be hypotensive. Okay. And then you want to verify their polyuria. So you would do a 24-hour urine output collection. And then usually it's greater than 50 milliliters per kilogram per day. And then you can also check their osmolarity, and that just kind of tells you if it's greater than 300, it's usually from something else. But if it's less than 300, then it's usually some form of diabetes insipidus, whether it be central or nephrogenic. And then you also, again, want to check their sodium levels, see if they're hypernatremic or hypernatremic. And then you can do what's called, to confirm it, is you do a water deprivation test. So you're measuring their urine volume, their osmolarity, and you do this by the hour, and then you do a serum osmolality every 2 hours. So after 3 to 6 hours, or until your patient passes out, you would check the maximum osmolality in a patient if it's less than 300. But a lot of times what they do is they weigh the patient too on water deprivation. I might be doing something else right now. And then you can also do an MRI, but looking at the hypothalamus or pituitary gland doesn't rule that out because it's more damage within the cell than itself. I'm sorry, you can't diagnose it just by an MRI. You can look at the MRI to see if there's a tumor in the cell, but you can't diagnose it with just MRI. And then how do you determine if you determine that they have diabetes insipidus? How do you determine if it's nephrogenic or central? You can administer them desmopressin, which is a synthetic version of ADH. And then, like we said earlier, an increase in 50% will indicate central diabetes insipidus. And if they don't respond at all or have very little response, then it's usually a nephrogenic cause. And then treatment is pretty simple. You would give them desmopressin, and then in mild cases you want to increase their fluids. So if you can equalize their fluid volume. You can do it that way, but severe, you'll have to give them desmopressin. And these are found in injectables, nasal sprays, or the pill. And a lot of times these patients aren't, it's just one and done, so a lot of times they'll be given desmopressin as needed case. And then for nephrogenic diabetes, diabetes insipidus, you don't give them desmopressin, right, because it won't work. So you give them a low salt diet to help reduce the amount of urine that the kidney makes, and then you increase their fluids. And I thought this is interesting, you give them HCTZ, which is usually a diuretic, but in some they can actually reduce urine output. And then gestational diabetes, you give them desmopressin, and then actually, delivering the baby. And then dipsogenic, there's really no treatment for that. It's because usually, like I said, it's usually psych-related, but you just would decrease their fluid intake. And then you guys, the doctor, we're going to talk about SIADH. And then you guys got it in neurology. I remember that one physician, nephrologist, he kind of talked about it. So SIADH is the most common cause of euvolemic hyponatremia in hospitalized patients. So it's defined as hyponatremia and hypoosmolality that results from inappropriate continued secretion of ADH. So these people, they're going to be retaining their water, right? So in their cup, it's full of water, so they'll have less sodium in the cup. It dilutes all the sodium. So it's not actually that they have a decrease in sodium, it's just you have the over-concentrated urine. And in these patients, you'll have excess ADH, water retention, elevated urine osmolality, decreased serum osmolality, and then, like I said earlier, the hyponatremia is a result of excess water and not actually a deficiency of sodium. It's just too much water, same amount of salt. So again, these are just different causes that can develop SIADH. Usually these people are tumors, usually after trauma, drugs, and I think Dr. Latassi will go into that about the types of drugs that can cause SIADH, and then pulmonary infections or infections. So these are symptoms of SIADH. So they've seen water intoxic. So they don't actually have to be edematous, but they'll have headaches, confusion, ataxia, nausea, vomiting, and anorexia, and then at its worst they'll have developed seizures and coma. So some people will have really severe hyponatremia, maybe asymptomatic. But the anorexia and nausea malaise can be seen early when their sodium is less than 125. Further decreases can lead, like I said, to headache, muscle cramps, confusion, weakness, seizures, and comas. These occur as the osmotic fluid shifts, results in cerebral edema and intracranial pressures. Most of my little old ladies that would develop SIADH, they really weren't symptomatic, but their sodium levels weren't super low. And how do you diagnose SIADH? You want to get a good past medical history, because some people who are suffering from chronic pain or high levels of stress, that can be confused with SIADH, why they have an abnormal release of ADH. Drug users. So physical exam, they'll be euvolemic and normotensive. Now if it's severe or rapid onset, these people will really be really confused about muscle weakness like we talked about. But these people are usually hyponatremic with hypoosmolality. So what I was saying when I was reading it, if you can figure out, if you can be really good at knowing one, then the other is the opposite for SIDH and diabetes insipidus. So just kind of remember that, which if you do the cup thing or whatever, if you can remember one really well, then the opposite will be true for the other disease. So with these people, so they have serum hyponatremia, it's usually less than 135, and then the serum hypoosmolality, which is less than 280. And then they'll have urine hyperosmolality. And then how do you treat these patients? The goal is to correct the hyponatremia. So, but you don't want to do it too fast, right? Because then you'll have hypernatremic issues. So it's a fine line about how you correct their rate. So they come up with a rule called its rule of 6. So you raise the serum sodium by 6 milliequivalents per liter in 24 hours. So 6 a day makes sense for safety. 6 and 6 hours, so 6 and 6 hours for severe symptoms, and then you stop. And then a lot of times when you do the correction, you want to give them fluids, obviously, and then you give them hypertonic saline along with the vasopressin receptor antagonists together. And then you can also give them furosemide. See, again, this one makes sense with furosemide, right? Because they got too much overload. That's why I have to go back and research why HCTZ is good for diabetes insipidus. And then for chronic SIDH, you give them fluid restriction. And again, you can give them vasopressin receptor antagonists and then chronic loop diuretics. I was going to put a funny meme, but there was no funny memes to go with.